Hi everyone, welcome to Dr. Deepa's Learning Launch. I am Dr. Deepa, and again we are going to discuss the second session of resident reporting dilemmas. As I told you already, every day we will discuss one crucial differential which usually put residents in dilemmas, whether it is the exam or is it during the early stages of reporting. So today we will discuss a very important topic which is in breast core biopsy, and it is always a doubt for the residents to differentiate a DCIS from an invasive and a microinvasive carcinoma in a core biopsy especially. So one of the most anxiety provoking diagnoses for pathology residents is deciding whether the breast lesion is DCIS or is it an invasive lesion, and is how is the stroma surrounding it. The distinction is very crucial because the diagnosis changes the entire staging of the patient. It changes the surgical approach, it changes the prognosis, and it changes the adjuvant therapy. So today I'll share you a very systematic approach to use while reporting breast biopsy. So why is this distinction important? That is what I just explained. The first step for any diagnosis, any reporting in pathology is to look at a lesion only in low power first. Scan the entire slide and then look at it in low power. Never jump to high power directly. An experienced breast pathologist always looks at a scanning magnification first. The low power will give you a good clue of the architecture, and the architecture is often more important than the actual cytology of any tumor. Before looking at the nuclei and before deciding if the lesion is having within the boundaries or no, look at its architecture in toto. So that is the first important step. So that is the first step. Look at it in low magnification. Then see if there are any features that are supporting a DCIS diagnosis. DCIS remains more pre-existing to an invasive carcinoma in most lesions. Even though the cells look malignant and they are looking very dangerous, they have not yet breached the basement membrane, and that is why you are calling it as an in situ lesion. One of the biggest clues is preservation of the duct architecture, that you can pick it up even in the low microscopy. Notice that the ducts remain more or less rounded and sharply circumscribed in the low power itself. So think of a contained disease. So as the mnemonic suggests, I have mentioned a mnemonic here for you to always remember. DCIS, ductal carcinoma in situ, is also disease confined inside spaces. That is a mnemonic that I'm giving you for DCIS, disease confined inside spaces. Always remember, the neoplastic cells are confined within the ducts, basement membrane is intact, the peripheral myoepithelial layer is preserved, rounded duct contours are seen, there is no stromal desmoplasia, and there is no isolated tumor cells in the stroma. That is how you know that the lesion that you're looking at is DCIS. And the features that actually suggest an invasion is also an architectural diagnosis. When the tumor cells leave the duct and infiltrate the surrounding breast tissue, they lose their organized growth pattern. And that you can pick it up even at low power. The desmoplastic stromal response also to a certain extent is the first clue for you to understand that there may be an invasion in that area, that you can pick it up in the low power also. So these, when you go in a higher power, it is reconfirmatory. That is why I said for any breast core biopsy, if you want to differentiate DCIS versus IS, you should always start looking at it only in the low power. Okay, so if there is an invasive carcinoma, you have to think of it only when the tumor is escaping the ducts. Whether it is an irregularly angulated duct you're able to see, or a single infiltrating cell in the stroma, or you're seeing small nests here and there in the stroma, or there are cords of tumor cells escaping the duct, or if there is too much of desmoplasia around the ducts or loss of normal architecture, think of an invasion. Am I clear? Then also an important clue is, if I am uncertain, I mentally ask these 5 questions to myself, and the checklist prevents you from making a wrong diagnosis. What is the checklist? Is the myoepithelial layer intact? That is the first question. The next is the basement membrane intact? Is there desmoplasia? Are tumor cells infiltrating the fat? And are glands irregular or angulated? If your answer is yes to the last 3 questions, think of an invasive carcinoma and not a DCIS. If you look at the histological clues on the differentials of the two, DCIS generally has rounded ducts, continuous myoepithelial layer, basement membrane being intact, no stromal response, and no tumor cells in the stroma, while invasive carcinoma has angulated ducts, loss of myoepithelium, basement membrane breach, desmoplastic stroma, and tumor infiltrating the stroma. These two, this is the main difference between DCIS and an invasive carcinoma. Notice that almost every feature revolves around the architecture only and rather than the cytology of each of these cells. So the nuclei, although they look identical in DCIS and invasive carcinoma, it is the architecture and the invasion that make out the difference. It is not the cytology of each cell. That you have to be very careful about. And another question that commonly residents are doubting is, should we order an IHC or no? If the morphology is classical, do not order an IHC at all. It is only for reassurance. If you're sure there is an invasion, you don't have to order an IHC at all. Reserve it only for cases in which you have a doubt. For example, if there is a tangential cut and you're not very sure if you're actually looking at a tangential cut and some areas look like there is a breach, but you're not very sure, take a recut and see. Even if then you have a doubt, then do an IHC. So consider myoepithelial markers that are useful include P63, smooth muscle, myosin heavy chain, calpunin, smooth muscle actin. And basement membrane IHCs are collagen type 4 and laminin. In some situations, you can use them. But make sure that you do not order an IHC if you are having a clear architecture. It is of no use. It is only for reassurance. And there are some common pitfalls that residents have to keep their eye open. Mostly there can be an overcall in these mimickers, benign mimickers that stimulate infiltrative glands. So when you have sclerosing adenosis, a radial scar, microglandular adenosis, tangential sectioning, or retraction artifact, or crushed biopsy tissue in which the biopsy itself is not taken. There are repeated punch biopsies taken next to each other, and then you're not sure. And then these are the things that mimic invasion. So you need to have a good clinician kind of a relationship in which you can call them and ask, how was the biopsy taken? And you need to keep your eyes open for these mimickers also. So the main example, always remember the most important example, many residents are influenced by marked pleomorphism or necrosis. Please don't get confused. High-grade DCIS can look cytologically identical to an invasive carcinoma. Always make sure you are following the 5 questions that I asked you. Ask yourself those 5 questions. Call it invasive only when there is true invasion. Do not call it invasive when you're in doubt, because the entire staging changes. Diagnosis of invasion depends on the architectural evidence of invasion and not just how dangerous the cells look. Okay, it is not the nuclear grade at all that influences the difference between DCIS and invasive carcinoma. Don't diagnose an invasion. That is why when the tumors look aggressive, look at the morphology first, look at the architecture first. IHC only for reassurance when the morphology is equivocal. If your eyes are focused on the ducts and you're seeing ducts in a good architecture, think of DCIS. If your eyes are drawn towards the stroma and you're seeing desmoplasia, if your eyes are getting drawn towards the stroma, you're able to see some mushrooming, then think of invasion. But then again, look at the myoepithelial cells and basement membrane. Be sure that it is invasive before you call an invasive as an invasive. Okay. So let's look at the slides now. So this is DCIS basically. What you're able to see is that now I'm not hardly looking at the stroma. I'm only looking at the ducts, right? It is definitely some of them are tangentially cut. But if you look at the ducts, you're able to see beautiful myoepithelial lining right around the ducts, right? So you're able to see all these myoepithelial cells right around the ducts everywhere. It is fully lined by the myoepithelial cells. And the basement membrane is also intact. If in the lower power when we saw, my eyes were not getting diverted into the stroma at all. Each and every duct is lined beautifully by the myoepithelial cells. So this is undoubtedly a DCIS. It is not invasive. Okay, am I clear? When I'm going back to the lower power, you're seeing my eyes are only looking at the ducts. I'm hardly able to see any abnormality or desmoplasia in the stroma, correct? So this is a classical DCIS. Next, let us look at the invasive tumor also. So this is invasive. If you're able to see that I am looking at the stroma right around, it is not, the duct architecture is definitely looking distorted here. And where in the lower power itself, we were able to look at the desmoplasia right around the tumor as well. So these are, if you're seeing this is a mushrooming area, you're able to see clear mushrooming in this area. You're seeing that it is getting invasive here. The basement membrane is breached. There is enough desmoplasia right around the ducts. So this is invasive. Call it invasive only when you're sure that it is invasive. There should be a basement membrane breach. The duct architecture should be distorted. There should be clear mushrooming. There should be desmoplastic stroma. There should be breach in the basement membrane and lack of myoepithelial layer for you to call it invasive. Okay. So I hope both my slides are clear. So you're able to see even in this, there's nicely a breach. There's a mushrooming around beyond the architecture of the duct. There is clear invasion right around. So this is classical of an invasive carcinoma. So I hope I made the difference clear to you. So, as I already said, the very important example, don't diagnose an invasion because the tumor looks aggressive at all. Always call it invasive only when it escapes the duct and you have evidence of that as a breach in the basement membrane, lack of myoepithelial layer, mushrooming out from the duct, and a desmoplastic stroma around. Don't look at the nuclear architecture or how dangerous the cells look like. DCIS versus invasion is not a nuclear diagnosis, it's an architectural diagnosis. So think of DCIS when the lesion is confined within the ducts, when the intact basement membrane is present, continuous myoepithelial layer is present, and the rounded duct contour is maintained, and there is no desmoplasia and no tumor cells in the stroma, like the first WSI that I showed you. Think of an invasive carcinoma if there is irregular or angulated ducts and breached basement membrane, loss of the myoepithelial layer, desmoplastic stroma, and if there is tumor that is infiltrating into the stroma and there are cells and nests and cords around, like we saw in the second whole slide image. So the questions that I told you that you have to ask yourself is the myoepithelial layer intact? Second is the basement membrane intact? Third is fourth is, are tumor cells invading the stroma or the fat? And fifth is, are glands irregular and angulated? And if your answer is yes for the last three questions, then call it an invasive. Okay. So you have to call it an invasive only when you have evidence of invasion, and you cannot call it on the basis of how scary the cells look like within the DCIS itself. So if you consistently follow this checklist, you will avoid two biggest mistakes in breast pathology: overcalling an invasion and missing a microinvasion both. Microinvasive DCIS is again another entity which is equalized to T1A of invasive carcinoma for treatment, and for the entire treatment protocol is very similar to T1A invasive. So micro invasion is also something that you have to notice, which you will be able to see when you take this checklist seriously. So remember, even in the most difficult breast biopsy, it becomes very easy when you follow this checklist, that you have to start at low power, evaluate the architecture first, look for stromal invasion, look for desmoplasia, assess the myoepithelial layer, and look at the basement membrane as well. Use IHC very selectively only when you have an equivocal type of diagnosis or you're not very sure. IHC is not required. Okay. I hope you like my video. So for many such videos, please stay tuned to www.drdeepaslearninglaunch.com. So we are available in all social media. So I will be giving you such lectures on daily basis. Stay tuned. Don't forget to subscribe my YouTube channel and share it with your peers. Bye-bye.